computer. The school got mad. They're going to start deleting cloud account for Zoom. So I'm glad I hadn't been saving on cloud because they're about to erase some of that. So I think we made the right call on saving it to our individual computer here. All right, that y'all didn't care anything about that. All right, so here we are. We're labeled immunoassays. I did notice last night, nobody's mentioned this, but when I've been editing these PowerPoints, the font's awfully small. I mean, I'm pretty good with my eyesight at my age, but some of you may not be that good. So I'm gonna, once I printed it again, I'm like, I really need to increase the font size on some of these. They're really big to begin with, but then when I put the cool stuff in them, then it decides that the chapter label needs to be big and all the info needs to be small. All right, so what are we doing today? We're going to look at formats for labeled assays. So like I said, the principal part of immunology is over. You know, the hard stuff. Now we're doing the testing. So what am I going to do with all the info that we went over for 2 units? Now you're learning what you're going to be doing with it. Now we're going to talk about heterogeneous and homogeneous assays, radioimmunoassays, which we will not be doing here on campus, so you don't have to worry about that. We do not do radioactivity here. Enzyme immunoassays we will be doing today. This is the one you're doing today. Okay. Fluorescent immunoassays, we have that capability on campus, and we have chemoluminescence ability, but it's mainly, so far what I've seen since I've been here, it's over in the ABI. ABI has fluorescent scope, ABI has this, ABI has that. So a lot of the cool research stuff has been put in ABI, but we could still do this. I've been to conferences where there'd be a salesman show up with a fluorescent objective for your scopes. So you could do fluorescent in the lab right on the scope that you do for DIPS or do for anything, do gram stain on. You just change out one of the objectives and it's really close and it darkens and it picks up the fluorescence if it's there. So that's not out of the question. Okay, so that's kind of where we're talking about today. So it's test day, as we say. But there are some keys to these tests that you got to get straight and get the idea, the principle of ELISA that we're going to be doing today. Or you're going to be confused and you're just going to do it. You're going to say, I have no idea what I just did. Hopefully we can get that straight before we end up down there this afternoon. So the labeled immunoassays are designed for antigen antibody detection, one way or the other. We're going to use those together. So we may be looking for the antigen. And so we'll use an antibody. We may be looking for the antibody. We use an antigen, but we'll also use a secondary antibody in a lot of these cases. The good thing is that we can detect low concentration. So we know that, when you think about PCR testing in the nose, swabbing my nose looking for, a virus. We know viruses are very small. We know they did a drill through my nasal cavity and sent it off, and we did all this extraction on the swab to find the virus particles, and then we amplified them with polymerase chain reactions, and it takes all day to get that test done, right? That's kind of the principle behind COVID, right? A different technique. But then we've got this antigen capture that's going on now, all right? So how are we capturing the antigen? We're using antibody against it. So the test is developed with a monoclonal, mix it with, run that swab through a wash, run that wash over an antibody bed, and if the antigen's there, it latches on. So we've talked about the latching and the interaction between antigen and antibodies in the first 2 units. So basically what we're doing is we're going one way or the other. So today in lab, we're going to detect antibody. All right, so we're going to go to the COVID antibody test, and we're going to say, hey, we're screening the patient's serum for antibody. And we're going to do what? What are we going to load into our testing material? What do we need if we're trying to detect the antibody? Antigen, right. So we're going to have an antigen that we're going to place into a well and latch onto a well. And then we're going to put antibody on top of that. Okay, then we'll wash that out. And then we're going to put another antibody on top of that that's got detection. If it binds to the first antibody and it stays there, then we have a color change. And that's basically what we're doing today. All right, real simple. So we're going to label a reactant, which would be our antibody, to monitor the amount of what we're binding has taken place. We can measure analytes such as bacterial antigens. That's good, right? We love that. Hormones, we do it that way too. Drugs, tumor markers, and specific immunoglobulins. So our IgG, IgM testing is performed this way, the immunoassay. So we did that antibody titer, right? Where we were looking for antigen-antibody reactions as we came across diluting it. That was setting you up for, hey, now we're going to be able to measure, right? We're going to be able to measure the amount of antibody there based on a color change. So this is the hardest part about today's lecture, is this competitive versus non-competitive. Try to keep it simple, okay? Because these words are simple. Don't let the whole big shoot match get a hold of you and you go, oh, I'll never know what this means, right? So it's real simple. All the reactants are mixed together simultaneously in a competitive immunoassay. So you're giving everybody a chance to react, right? You put them all in there together. The labeled antigen, okay, so we're going to label the antigen, competes with the unlabeled patient antigen for a limited number of antibody binding sites. Okay, so got to dissect that one sentence. Let's take a look at it. So to set up a competitive immunoassay, we're going to take labeled antigen. So we're going to know how much of that we're adding. We got an antigen label, and we're adding that to the sample. The thing we don't know is the patient antigen. Okay, we don't know. Patient antigen, we don't know how much is there. It's unlabeled because we didn't have it to start off with. We're testing for an antigen. Look at it that way. But we do know we have antibody binding sites that we're going to mix in there together. We're going to mix antibodies to the antigen, whether it be labeled or unlabeled. We're going to put them all together, and then they're going to compete for binding. So there's going to be, you want to look at it this way, competition for the antibody, right? The antigen is going to compete. So take the principle. So if I told you that we have more labeled antigen than we do patient antigen, say the patient's negative, right? Patient's negative for the antigen we're testing for. Maybe they're negative for the flu. They're negative for COVID, right? So what are we going to have bind to the antibody that we put in there? The labeled antigen. Okay, there's no competition. There's no patient antigen there in the test sample. So all we're going to see is this label show up. So this might be a strength in color, might be a strength in luminescence. Oh, it's shining bright. Or we may have to measure it with some other machine. Okay, but that's the first idea, is that we put this in and we can do a competitive test where they're competing for the binding sites of an antibody. We know if it's IgM, it's got how many? 10. If it's an IgG, it's got 2. So if we added labeled antigen to the sample, let's take the reverse of that, and the patient had flu A, just loaded up with flu A. Okay? Then we would see what? We would see a decrease in the binding of the labeled antigen. And depending on how much is here, we may not have hardly any. And that would let us know how strong the patient had the antigen, how sick, what was the high level, how much of the antigen do they have. We could measure that. Okay? So do y'all have that? That's the first thing, just thinking about what we're putting in and how we're going about this latching. Who's latching on? The amount of bound label is inversely proportional to the concentration of the labeled antigen. Makes sense, right? So if one goes up, the other one should go down, right? If one's up, the other one should go down as far as the binding goes. That makes sense? Everybody good with that? Zoom, you okay with that? All right. So here's a picture of it from your book, from your text. This is 157. It gives us a principle of competitive immunoassays. That's what I love about this book. It gives some really good pictures. It also gives a little explanation. So number one, here we got two samples. Okay, we're going to look at it two different ways. Unknown concentration of the analyte in the patient sample is red dot. Okay, unknown concentration of the analyte is the red dot. So in sample one, is there a patient? Patient got any antigen? So this would be what? What would we say here if we got to this end? So our first example I just explained. Negative, right? They're negative for the flu. Because the only thing that's still here that's detected is what? Is what we added, right? The labeled antigen. The labeled antigen, not the patient antigen, the labeled antigen is the little suns. And they bind to the IgGs right here, okay, and light them up, okay, and we detect that. So it's kind of what we're doing today. We're going to get color change. Right? It's going to be, hey, if it's this, it's negative. If it's this color, it's positive. Y'all love color change, right? Everything changes. Sample B, all right, got patient B, got some flu, right? That's the red antigen. It's not labeled, right? The unknown concentration of the analyte patient is red dots, competes for the binding sites on the IgGs. Thus, we don't have is what? The reds aren't labeled. It's not like that's a red light, okay? Those are not glowing. The sun's glowing. So we get a decrease in the color, number 2. So number 2 would indicate a positive test. Number 1 would be a negative test. Okay, so they're competing for the binding sites. Good? So as you see over here, the analyte concentration with the signal, right? A is the first one, is a negative, really high signal. B, the signal's coming down, so, right, we're getting a little bit more of the patient analyte there. And then we can measure that. We can put that on a standard curve, and we can say, if our patient is here, then we know what level of antigen they had. Is that enough? A level for sickness. All right. Are we good with that one? Hopefully, okay. Because now we're going to flip the coin. We're going to go to non-competitive immunoassays, and these are usually used more. Let's put it that way. Non-competitive immunoassays are usually used more in the lab. So the antibody is first passively absorbed to a solid phase, okay? Which means as we have some kind of a base, whether it be a bead or plastic or cellulose of some kind, we've added the antibody to it, okay? So we've added the antibody, and then we put an unknown patient antigen is allowed to react with and captured by the antibody. So we just put the patient's serum on that. Or swab wash, if we want to stay with the COVID theme. We're still looking for the antigen, so it's flu, COVID, all right, swabbing noses, strep, swabbing throats. So all these swabs that you've heard about, we're bringing those in, we're washing them, and we're adding them to an antibody that we first put on the capture phase. We added that antibody. Okay, so on the setup of the test, we add the antibody. We wash over that antibody with the patient sample, okay, and give it time to bind, okay. And then after washing to remove unbound antigen, a second antibody is labeled with that bright, hey, we're going to change colors. It's going to go in and look for what? It's going to look for the antigen, okay. So it's called kind of a sandwich. So you're going to get an antibody, the antigen, and another antibody, okay? So if the patient did not have any antigen in the first, we put that onto the antibody. Let's just do this. We have nothing here to bind to our antibody, and we wash it off. We add the second antibody with our substrate to make an hey, if you leave me here, if I'm attached when you get through washing me the second time, I will light up that antigen and show you that it's there, okay? So there is no competition for the antigen-antibody reaction. If it's there, it's there. There's nothing going to prevent it from binding. So it's here, comes our antigen, our secondary antibody comes in with the big shiny sun up here, right? And lights that baby up if it stays there. If antigen wasn't there and we added the second antibody, it's not going to attach to the first antibody in the well. It's just going to wash off. So you're going to leave with no reaction. Okay, so this is a non-competitive immunoassay. It looks for the antigen. The antibody is going to make its move. And of course, we do have pictures for this one. So let's finish up. The amount of labeled measured is directly proportional to the amount of antigen. Okay, because what it's going to mean is if there's nothing to measure, there's no antibody there, there's no antigen there. If there's an antigen there, there's antibody there. Okay, and we can do this with radioactive substances, enzymes, which we're going to do today downstairs, fluorescent compounds, and chemiluminescent compounds. So let's take a look at this one. So here, a non-competitive immunoassay, sample 1. This is our antibody that we attach or allow to stick to the bottom of the well. Okay. Here, we put a sample in. It has no patient antigen. Okay, so number 1 is our negative. We put in our labeled antibody here, looking for the antigen. There's none there. We do our last wash, and we got nothing detected at the bottom. Okay, so a negative result. Yay. All right, that's what we want. All right, everybody gets their nose tested for COVID, wants a negative result, right? You don't have to worry about self-reporting, self-quarantine, or self-isolation if you're positive, all that good stuff. So that's what we're doing. Sample B here, we have the antibody, right, here. And we have patient serum, which did have the antigen in it. So this is our COVID or our flu here. And it attaches. Then we're going to put in our labeled antibody against the antigen. And it's going to attach. And it's going to change colors. So the second one is a positive reaction. Simple enough, hopefully. Now the third one is what we're going to do today. We're going to do antibody capture today. Okay, so we're going to label the well that you're going to have here. Everybody's going to have a little strip, a little well. I think it's 1, 2, 3, 4. I can't remember if it's 10 or 8 or 12. I can't remember. You're all going to have those. So you're going to work with those, all right, on your front of you. And we're going to try to label, we're going to put the antigen in first and give it time to incubate in the well and hopefully attach. All right? Then here we'd be looking for the patient's antibody. So this is a right opposite of what we did the first time. Because now we're trying to detect the antibody, and this would be COVID antibody testing. All right. So we're looking for the antibody this time. Did the patient develop an IgG to COVID? And if it did, hey, this is where we're going to detect it. So you see that the patient's antibody attaches to the antigen that's sitting on the bottom of the well. And then we're basically going to put in the labeled antibodies to chase the first antibody, okay, to attach to it and light it up if it's there. So if the patient doesn't have an antibody, there's nothing for the labeled antibody to attach. So thus it goes back to number 1. Except we got to change our little bottom there and put little antigens by themselves, so the antibodies by themselves. Okay, so this is what we're doing today. You're going to go downstairs today. You get to do this. It'll be fun. Okay? But keep this lecture, keep these 2 things in mind, because this is where we're going to roll Monday's lab and Wednesday's lab. We're going to flip this. We're going to look for the antigen today, or antibody today. We're going to look for the antigen tomorrow on Wednesday. Sorry, Wednesday. Questions? So that brings us to the types of assays. And I said we would not be doing this one, right? But if you were in research, previous life I've had, we did radioimmunoassays. We had a room that was considered the nuke room. And believe me, if you have nuclear med on your hospital from x-rays perspective, anybody's had a stress test, they sometimes will give the patient radioimmunoassays. They'll give them radioisotopes while you're jogging on the stress machine. And that way they can image the heart and watch for any blockage that the coronary arteries have. Okay, so that's a stress test in the hospital. That is a branch of radiology. It is a radioactivity. You have to be monitored. They have to know what they're doing. They have to keep it stored correctly. They have to wear not only their little X-ray badge, but they also have a radio badge over here for radioactivity badge. They have to wear both. So this is the first that were developed for us for immunoassays. Radioisotopes were used back in the 50s. This was done in 1950, 70 years ago, right? Not that long ago. The first immunoassay was developed, and it used iodine-125. It's the most popular. That's what the I stands for there. So if you remember chemistry, remember isotopes and how you go from, stable to changing these numbers, adding, subtracting. That's chemistry, right? All love chemistry. Remember, probably Gen Chem for this one. So we get gamma radiation, and we can detect it with a gamma counter. Right? I love the gamma counter. The gamma counter, little safety guy will come down to your lab if you're using this stuff, and you wait till they'll rum it on you, and then they'll rum it on the counter. And if it detects anything, it starts clicking faster. Y'all ever seen one of those, like in the movies or anything? No? Everybody's seen a gamma counter? Yes. Okay. They actually do that still. They actually come into your lab and wave a wand around your lab, seeing if you've spilled any that you didn't clean up and miss, right? It's a very good test. It measures a trace amount of analytes. So we do this with hormones, serum proteins, and vitamins. So it's very good. The thing is it's very messy. It's very health hazardous. We don't like these things in the lab if we have other options. And basically, there was a development of the enzyme assays that came after this, which we love because they're safe and they're fun. Okay, so here was the disadvantage. Working with radioactivity is never fun. Disposable of low-level radioactivity waste, and you had some short lives that if you didn't use it, you would lose its reactivity, and it was worthless at that point because it decays, right? Y'all know about radioactive decay. So we moved on to the enzyme immunoassays that we still use today. Instead of using radioisotope, iodine-125, we use enzymes as our label that react with suitable substrates to produce breakdown products. We can do this for chromogenic, fluorogenic, or luminescence. We can do all of that. We have different ways of doing it. You have one of these downstairs. I love this because it just sounds good, right? Anybody likes horseradish? Is that what it is? It's like, let's put shrimp in. What do they add to shrimp sauce? Cocktail sauce. What's in cocktail sauce? Anybody know? It has something that sounds like horseradish, doesn't it? Not horseradish peroxidase, but it's something horseradishy. No? Who's my cook? Who's the cooker around here? Anybody? Dietitian that knows what I'm talking about? Okay, we'll have to find that out for this afternoon. Anyway, we have horseradish peroxidase downstairs, and that's going to be our enzyme we use. Okay? And basically what it's going to do is going to be our reactant, our enzyme label. So we're going to have the highest turnover conversion of substrate rate. They have high sensitivity or easy to detect. So that's our label. Okay? We're going to label we're going to add, the first one we add is we're detecting the antibody, right? So we're going to add the antigen. We're going to have a patient sample that we're going to add then. And then we're going to have a labeled immunoglobulin to come in behind that. So we're actually going to put horseradish peroxidase with that and light them up. Okay? So it's going to be fun. So this idea of heterogeneous versus homogeneous. We have that coming up now. Oh, there's a very good formula. Sorry, I hate to get back. I don't have a slideshow. I'm looking at my book here. When we were talking about competitive immunoassays, this is where we get to use that ratio instead of dilutions. So the ratio of the antigen, labeled antigen versus the patient antigen, as you see, is a 3-to-1 ratio or a 1-to-3 ratio. So that is 1 part, 3 part. Okay, so that's why we leave those ratios there for us, and we don't talk about ratios with dilutions. We don't want to confuse that parts and dilutions, okay? Want to make sure I mentioned that. So heterogeneous enzyme immunoassays, EIA, you'll see that a lot, require a step to physically separate the free analyte from the bound analyte. Okay, so this one may not be what we like best, because when we go to homogeneous enzyme immunoassays, the antigen antibody system does not require a washing or separation state. Okay, so a little bit on those two. Whew, where am I? Here we go. So in the competitive assay for enzyme immunoassays, the competitive one involves enzyme labeled antigen competing with unlabeled patient antigen for the binding site on the antibody molecule. We just did that, right? That's putting to words what we just described with our picture that we first started with. Okay? So a competitive assay is we're putting labeled antigen with patient unlabeled competing for the binding site of the antibody that's in the mix. So we put them all together. Used for measuring small antigens and has a high specificity. Okay? So that's just kind of a review of what we actually described in the first slide. Non-competitive enzyme immunoassays offer a high sensitivity and specificity, and then their advantage is they're simple and low cost. So here is the one we'll be doing today, and you will need to know the name of ELISA, which is enzyme-linked immunosorbent assay. I know that's a test question in the pool where I mix up the names and add a few extra words. They all spell ELISA, but you must be able to tell me exactly what ELISA stands for. I will start. Enzyme-linked immunosorbent assay used to measure antibody production to infectious agents. Makes sense, right? We see that with HIV, hepatitis B and C, which is if the body produces an antibody, we look for it, okay? We do this for antibody testing against a disease or against a pathogen or against the viruses. It's easily applied to point of care and home testing, right? You can take home go to the drugstore and get you an HIV test if you want, right? Now I think they have hepatitis C testing at home too. Okay, so these are what we know as we like to call it, bleeding of our profession, which is these end up in the pharmacy. Okay, so we kind of lose, if this is your, as we like, it's kind of in your field of study, which is our field of study, is testing, especially immunology testing. Sometimes another profession gets to say, we can do that, right? And why not put it in the pharmacy? Pharmacists are doing vaccinations, right? Pharmacists are doing some COVID testing now, right? So some things get put on other professions that may not want those things. That's what I hear from pharmacists sometimes. They're like, I really don't want to do vaccinations. I really don't want to do testing in my pharmacy. I went into pharmacy to learn the drugs, fill the prescriptions, advise the patient on their drug interactions, but now you've got a popular store, you're accessible, it could be a great idea to give you this, right? So that's kind of how the professions get given stuff. And we have to say, you know, to the point where is there, I ask you this, is there a place where we can do lab testing? Is there a place that you know of that you can drive up to and get lab done? Just drive up in the parking lot, go inside and say, I'd like to have this lab test done. Is there? You've heard of it?
I thought it would be like any urgent care.
Any urgent? No, no. I'm talking about just a business. What I'm referring to is something like Shot Nurse. Y'all heard of Shot Nurse? Just a standalone in the strip mall. Shot Nurse. You need a hepatitis B vaccine before you go to clinical. You drive up to the Shot Nurse, walk in and say, I'd like to get a hepatitis B vaccine before I go to clinical. I need a TB skin test before I go to clinical. Okay. Shot Nurse, I don't know if they're here. I know they're in Memphis. No, they're in Memphis and South Haven, but I didn't know if they had one here or not. So I've always thought about just starting lab testing now, right? That way the patient could just drive up, pay for their lab test, get a result. I could do that. We could do that. So keep thinking, right? Okay. But to do the test, right? We could just load up our testing. We'd be ready for anybody that wanted one of these tests. It's kind of like the COVID test right now. That's lab testing now. Come up and get your COVID test. That's basically the principle behind this outbreak is setting up in the pharmacy a COVID testing. Hey, come by the health. We're going to put out a tent outside. We're going to load up Walmart parking lot. We're going to have you drive through. We're going to have somebody out there swabbing your nose to do the test. So you could see where it could be beneficial, especially when the state or the government are covering all the tests for you. They're paying them to test you. Okay, so everybody wants to be testing you right now because they're getting reimbursed. Okay, good. All right. So back to our topic of ELISA. ELISA is used here for testing. This one be looking for the antigen or the antibody, sorry, which we're going to be doing today. We're going to be looking for the antibody. The antigen is bound to a solid phase. Like we said, we're going to put that in our well. We got a plastic well downstairs. The patient's serum is then added of the unknown antibody. Whether the patient has it or not, we're going to give it time to react. Easy enough. We just need a wash. Or in this case, we don't need a wash. We need what? What would we do for antibody testing? What would we use for the patient? Testing for where are antibodies found? Put it that way. Unit 1, Unit 2, or Unit 3. Where are antibodies found in the patient? Is that a hint? Zoom, if you can't see me, I'm tapping at my my antecubital. Is this an antecubital area? So where am I finding my antibody? Blood, in the serum, or in the plasma. Right, that's where my antibodies to these illnesses are. Right, they're produced and then they're circulated. Okay, we know how they're formed. We know how the antigen makes it happen. So we're actually going to put patient plasma or serum into that well. We've got the antigen sitting there, and if that antibody is present, then it attaches, binds to this way. Okay. Right, the Fab region of the IgG is now attached to the antigen. Thus, we would have a second antibody that we add to react to the patient antibody. So a lot of our blood bank testing is based on this principle. Okay, the principle of using anti-human IgG searching for the antibody of the patient that may attach to the red blood cell and cause a transfusion reaction. Okay, you're going to get all that next semester, and I want to hear Dr. Walls say, wow, they actually knew how this works. Okay, that's our goal, right? Press the program director in the chair. is to say, I know how this works now. I know what I'm looking for. I know the antigen is the red blood cell, and the patient may have an antibody, may not have an antibody to that. And we're going to add the anti-human IgG chasing it. Okay? We're adding a second one here to bind to the first antibody. So it's antigen, antibody, antibody. Okay? So it does a double, not a sandwich, okay? It does a stack, if you want to call it a stack. 'Cause I don't think you can have a sandwich unless you got the antigen in the middle. So this might be an open face roast beef sandwich. How about that? All right. If no patient antibody is bound to the solid phase, the second labeled antibody will not bind. After a second wash, the enzyme substrate is added. The substrate's looking for who? Looking for that second antibody. Okay, not the first one, looking for the second one. The color amount, the fluorescence amount, the luminescence amount can be measured, and it's directly proportional to the amount of antibody that was found. Okay? So that's what we're going to do. That's what we got going. The horseradish peroxidase is added at the end as an enzyme looking for the second antibody. And if it doesn't find it, there's no color change. Okay? The capture assay, right? The capture one is the sandwich immunoassay, and it's best suited to antigens that have multiple determinants. Okay, so what we're talking about there is that we got it. The antigen is going to have to be bound twice at different spots. Okay, there's going to be, the antigen needs a lot of different antigenicity to it, right? It needs a second binding site, or this one doesn't work. Okay, so here you would have the antibody sitting in the well. The antigen would need to sandwich, get on that first antibody to be held, but then it needs, the second antibody needs a place to bind to. So it actually comes in and makes the sandwich of the antigen in the middle. We see this with cytokine detection, proteins, tumor markers. So we're using those things as what? We're using those as antigens. Okay? Detect a cytokine, detect a protein. So the excess antibody attached to the solid phase is allowed to combine with the test sample that the antigen would be in. That's what we're looking for. After an appropriate incubation, we add enzyme labeled antibody, which is looking for who? Looking for that antigen. The second antibody recognizes a different epitope or binding site, if you forgot what epitope was. And then the solid phase antibody completes the sandwich. It doesn't compete, it completes the sandwich. So anytime we're talking about sandwiches, we're talking about the antigen in the middle. Either a colored or chemoluminescence reaction product is detected. Enzymatic activity is directly proportional to the amount of antigen in the test sample. Okay, so you can probably, hopefully you're picking up where test questions are going to be coming. I'm talking about a competitive immunoassay. The enzymatic activity is directly proportional to the amount of antigen in the test sample. Okay, that's the answer. So I can change that choice to say it's indirectly proportional, or it's directly proportional to the amount of antibody in this. So we can change or tweak those names to really try to get you straight, not to confuse you at all, and make sure you know which is which and what each one's doing. Okay? Very important. So what is a homogeneous enzyme immunoassay? These are antigen antibody systems that do not require a washing or separation state. Okay, so this is what we use mainly in the lab. Not downstairs, we're going to wash downstairs. We're going to use heterogeneous downstairs. But in the lab, we do a lot of just put it on there, let it wash across or let it move across, and you don't have to worry about trying to wash off any excess. It's all there. So we see this in strep tests. Okay. So the enzyme activity is directly proportional to the concentration of the patient antigen or the hapten. Hey, nothing changed there. When the antibody binds to a specific determinant site on the antigen, the active site on the enzyme is blocked, resulting in a measurable loss of activity. Okay, so this is going to be once the first binding happens, okay, there can't be any second binding going on. They're less sensitive, but they're rapid and simple to use. So they are used to determine low molecular weight analytes in the serum or urine, meaning hormones, therapeutic drugs, drug of abuse. Anybody want to throw out one that they're real familiar with here? Maybe. Anybody got kids? Nobody has kids. Nobody has kids in this room. Wow, that is
Heather does, but she's.
Heather's on. Yeah, Heather. Yay. Heather. Wow. Okay.
Yeah.
I am getting old. I figured we had more kids in the room. Never mind. So what would be one of the things we may test this way? How would we do this?
Hey.
Hi. I'm thinking about HCG.
Let me hear.
Right? Antibody to HCG on a test strip. HCG comes across when the placenta is producing it when you're pregnant. Okay, and that HCG acts as the hormone detected that we're looking for. So when you see hormones, that's what we're doing. Okay, so these principles are for more than just, do we actually have COVID? Might be just detect to see if we're pregnant, see if we have cancer, all those good things, right? More so with the pregnancy than cancer. Drug of abuse, bind THC, all right? Bind cocaine, meth. Yep. Okay. So you can see how these principles are being used, hopefully. They're usually membrane. So rapid immunoassays are membrane-based, single-use, disposable assay. Buy them at the store, take them home. They involve antigen or antibody being coupled to the membrane, are read by looking for a colored reaction, right? Now they're real fancy. They might even say pos or neg, or might even spell out positive or negative when it comes to these drug screens or the pregnancy test. They may require the separate addition of a patient sample, a wash reagent, and then they have the labeled antibody or antibody in the test strip itself. Okay, so here's how this works. This is rapid immunoassays. Immunochromatography is what we call this one. So you've added your sample here, clinical sample added to one end of the test strip. Capillary flow takes it to the other end. And then you see a conjugate pad here with monoclonal antibodies to the analyte with colloidal gold. Okay, so we've got some gold on there. All right, so then that sample washes across that conjugate pad. And as you see that it actually picked it up, right? The red is our sample, our analyte. And it's moving toward our antibodies, whether it be for binding of that detection here, or if we didn't pick up any of the analyte here, it would bind here to the second one and give us a control line. So I don't know if you've ever done one of these, but there's always a color line at the end that tells us that the test actually worked. That means that this initial antibody that we added to the test strip actually gets to the end. Okay? And it will. There's enough there that no matter if you have a positive binding or not, it's going to get there. Okay? That's how we do it. So the test line lights up, changes to red. The control line changes to blue. Okay? Whether it gets there without it or not, it's going to change both of them colors for a positive. It's not going to be this. So this will be a negative. This will be a positive test and a valid test. So that's how we work those. And we will be doing these. We've got new boxes of stuff that we're going to be doing this with. And what we're going to have to do, you're the clinical lab scientist now, you're going to have to really tell me how they work. Okay, so we'll be more interested not just doing the test and getting the result. We're going to be more interested in how it's set up. What is the procedure? What is the technology behind the test? All right, so we got fluorescent. Any questions on that? We got a few more, right? Just talking about the fluorescent immunoassays and the chemiluminescence. And we'll just, since we don't do these, we'll just kind of move through a little bit. We might have a chance to do fluorescent, depending on how advanced our lab is. And if we go into the research side, we'll definitely probably be doing some chemiluminescence. But we just have a fluorescent against a dark background. And then the same idea comes up: direct immunofluorescent, indirect immunofluorescent. We've got, I think we have that down. This is a picture of it. Here's our antigen, patient antigen in a solid phase is attached to the antibody with the fluorescent antibody. Here is the indirect. And basically the difference in those two names is, do I directly bind the signal to the antigen, or do I indirectly bind? Which means I got somebody in between us. So this would be the indirect here. We have the antigen, we got the patient antibody, and our light up is bound indirectly. Does that make sense? No? Yes? Look at it again, because this is key to what we need to finish with. When I talk about direct assays and indirect, direct means that my antibody against something with the fluorescent label, the label is what I'm looking for here, directly binds to the antigen. Okay? You're going to see this in blood bank. Maybe she's out there listening. DAT, direct antigen testing. And then we do indirect antigen testing. So here's direct. Here is indirect. The antigen's here. The patient's antibody detects it. Then we detect the patient's antibody. So the actual label is not attached to the antigen. It had to attach to the patient antibody first. So this is direct. This is indirect. And it's just is it right on the antigen, or is it linked to the antigen with something in between? I think when we talk about it more, it'll hopefully clear it. The last one is fluorescent polarizing, meaning if it's bound, it changes its shape or moves, and it polarizes the light. And then lastly, chemoluminescence is another way of using it. Okay, and that's seeing the different fluorescence, chemoluminescence. I think the principle's the key, learning the principle behind the different competitive, non-competitive, and then we'll focus on immuno ELISA today, right, downstairs. All right, that's it. I've got the wipes. I'll let Zoom go. Find it. You need to stop the share for sure. There we go. All right, we'll let you guys go in the meeting.